It's Keisha, and I welcome all of you. I hope 2019 has been off to a great start. I can't believe it's the last day of January already. We're thrilled to be together. I'm thrilled to be together with all of you for today's PAPRN Plus call, and we have a great speaker. And before we get there, we'll work down our agenda, and I want to just acknowledge all of you who are on the phone today and on the chat box. And we're talking about the weather, and we see some, I think Renee, who's in Waco, said it's 52, and we heard Amanda talk about it's only 64 degrees in San Diego, and we really have sympathy for everybody who's being affected by the polar vortex. So stay warm, and yeah, we are all thinking about you. So let's go ahead and begin with some CDC updates as we normally do. So Tom will get us started.
Yeah, what I'd like to do is just, for the people coming to the working session at Active Living Conference, is just remind people sort of what our goals are. And one of them is, as you may know, the conference name has changed to Active Living Conference instead of Active Living Research. Part of our goal is to put the R and the D back into that so that we have a chance to update the research you guys have been doing and also plan some dissemination efforts. And so the working session will focus on both an update of the research and then spend some time thinking about dissemination products and dissemination audiences. And so both for the work groups and for the funded projects, those are our overall goals. And Keisha is going to talk a little bit more about the actual framework for those meetings. Thank you.
Great. Thank you very much, Tom, for that introduction. So as Tom was saying, we have our upcoming meeting at the Living Conference, and there are 2 dedicated times that we'll gather. And one thing that we're going to do, as Tom just mentioned, is really focus on dissemination. As everybody knows, this is the final year of our current PAPRN Plus grant, and there's been a number of research initiatives and projects that have been going on over the last several years, and many of them are getting to the point where they have findings to disseminate. We also have projects from the working groups that are getting ready for dissemination. So one thing we're doing is we have created a research brief template. We recently shared these with the collaborating centers, and we're asking people to start to get them together. We understand that, you know, not everybody has key findings yet, but we know that they will be coming soon. And part of the plan will be to get these templates together in support of broad dissemination to a variety of audiences. So we will be working through the research brief templates with our collaborating centers and our work groups, again, just to make sure we are telling our story in terms of the work that we've all been doing over the past several years. And more on that over email in advance of the meeting, and then also when we are at our in-person meetings. Speaking of our in-person meetings, I just want to let everybody know, just so folks are aware of what's happening. The collaborating centers are meeting on the Monday of the ALC conference, Monday morning at 7:15, and we'll have some guests from the CDC there in the meeting and spend time doing some brief project updates, but really spending the majority of our time on dissemination planning. We'll be going through some dissemination-related exercises, having some time to brainstorm in our individual teams and also as a larger group. Again, thinking through who are the stakeholders that we're sharing our work to and what are the plans to get research findings out to appropriate audiences over the next several months. In addition to the collaborating centers having a meeting, the working groups will also be meeting, and that meeting is happening on the Tuesday of the ALC conference. And we'll send out something with the rooms just to let people know where these meetings are occurring. But that one's occurring over lunch. There are no scientific sessions at that time, which is why we picked it. And so we hope that people will grab their lunch and join us for a discussion, again, also around dissemination, as Tom said. And really, we'll talk about the research brief template and how we can use that for certain projects, and really thinking through how are we going to move things forward, in addition to what's the future of the working groups. You know, after the project or this grant currently ends, the grant we're currently funded by ends, what's the future of the working groups? And so we'll spend some time discussing that as well, and hope to have your participation. For those of you who are not attending the ALC conference, I'd love to hear from you. Feel free to reach out to me directly. Happy to hop on a call with you to talk through these issues in terms of your perspectives on the working groups if you won't be there, or feel free to send your thoughts over email. we'd really just love to hear from everybody around dissemination and also the future of the working group. Let me pause there and see if anybody has any questions for Tom or myself or Amanda before we transition to our presenter for today.
So Jeanette did ask, I got your question in the chat box, Jeanette, about the Monday morning meeting. So that one, the Monday morning meeting will be just the funded collaborating centers. We'll be specifically focusing on those projects. And so those will be just for the funded projects. And then the working group conversation will be around the projects and the working groups. And even if, I guess, there's people that are not in a working group, but you're interested in PAPRN and you're part of the PAPRN network, you're welcome to come to that working group meeting and, just kind of catch up and hear what they're working on. And there may even be a project or something that's still ongoing that you might be interested in joining on to. So good question.
Great, thank you, Amanda, and thanks for your continued support of the working groups. And I want to echo Amanda's comments that even if you haven't been as closely engaged with the working group as you would have liked to date, we welcome your participation and input at that discussion. Again, we will send out the locations for those two meetings in the near future. Any other?
Just a quick interjection. I think people might be interested to know that the exercise we'll be doing is similar to what the park group did, and that they were very successful or are being very successful in developing dissemination projects. And Keisha and Amanda have been involved with that as well.
Yeah, thanks, Tom. Okay. Well, we'll have time at the end for open mic if there are additional questions or comments about the ALC meeting. But now we're going to transition to our speaker, and I am so thrilled that Dr. Janet Fulton is going to be speaking with us today. And I'm sure everybody knows Dr. Fulton. Let me go ahead and read her bio, just introduce her to everybody. Dr. Janet Fulton is an epidemiologist, and she's also chief of the Physical Activity and Health Branch in the Division of Nutrition, Physical Activity, and Obesity at the CDC. She has a PhD from the University of Texas Houston School of Public Health, and she's been a leading expert in studying patterns of physical activity in the U.S. and working to make opportunities for physical activity a national priority, most recently by advancing a new national initiative called Active People, Healthy Nations. She has over 100 publications. She has just been involved in a number of national initiatives, including being a member of the writing group for the 2008 Physical Activity Guidelines, and most recently the Physical Activity Guidelines for Americans' second edition, which we'll hear about today. Dr. Fulton is also the recipient of the American Heart Association 2010 Stephen M. Blair Award for Excellence in Physical Activity Research. So let me go ahead and turn it over to Dr. Fulton, and thank you so much for making time today to talk with us about the Physical Activity Guidelines for Americans, second edition that was just released.
Great, thanks, Keisha. That was really great. And thanks everybody for being on the call today. Thanks to Tom and to Amanda for the invitation. I'm really happy to be talking about something that we've been working on for quite some time, actually, several years now. And these are the Physical Activity Guidelines for Americans, the second edition. And I'm hoping that you're familiar with the first edition that we put out in 2008, but this is an update of those guidelines. So I'm going to go through them. And hopefully the slides are advancing. Let's do this. There we go. Okay. So what I want to do today is just talk a little bit about how the guidelines are developed. Not necessarily kind of all the sausage making of them, but just a little bit about the process so that you're familiar with it. And then what I want to do is concentrate on what's new and exciting, and in that talk about the key guidelines for youth, for adults, as well as for older adults, and then finish up with how we can all work together to promote the guidelines widely, which I think is really what PAPRN is most about in terms of thinking about policy research to do that. All right, so this is just a little schematic that kind of walks you through. It's really a two-phase process to develop the physical activity guidelines. It starts with an advisory committee that's put together by our department, the Department of Health and Human Services, and you can see all these experts here in the photo. They're an advisory committee that really functions as part of a kind of a federal process, and they're put together for a couple of years, and they have a really huge task, and they review all of the scientific information on physical activity and health. And they did that for a variety of different health outcomes. So think about the effects of physical activity on heart disease, cancer, bone health, even looking at things like sedentary behavior or the acute effects of physical activity on health. They reviewed all of that information over the span of a couple of years, and then they put out a scientific report. And this report is really meant to guide the federal government in developing physical activity guidelines. It's an independent report put out by the advisory committee, and you can see that in the middle of the slide. So once that report is published and put out, you may have seen it. It's really useful if you're interested in doing research in this area because it has many key research questions that are at the end of each chapter. So if you haven't taken a look at it, don't print it out because it's almost 800 pages, but do take a look at it because I think, you know, obviously the information in there around the evidence is really useful, but I think also the research questions that are in the report are useful as well too. We want really, you know, the committee wants to review the research, but also guide research in this area. So then the next step is the Department of Health and Human Services puts together a writing team, and their job is to take the scientific information and translate it into guidelines for physical activity that can be used by health professionals as well as key decision makers. So this is really a translation document that really sets federal policy on physical activity across the federal government. So that's how it's done. Now what I want to do is kind of tell you a little bit about what's in the guidelines. So the advisory committee, I think one of the beauties of that report is it highlights all the additional benefits that physical activity has on health. And this is really just a picture of all of those different diseases or conditions where physical activity is beneficial. So now my count is there's around at least 30 different conditions where physical activity can help. And so I think it's even more, the evidence is even more strong now than it was previously in 2008 when we did this. So I think one of the key things and one of the kind of the new pieces around the evidence is in terms of thinking about short-term benefits as well as long-term benefits of physical activity. And these are things we sometimes think of them as acute effects. So here you can see there's now acute effects for a variety of different conditions, including sleep and anxiety, you know, two kind of prevalent conditions in the population. We know about long-term benefits for many things like hypertension, cardiovascular disease, but now we know about them for many aspects of brain health to include cognition, Alzheimer's disease, dementia, as well as information and evidence for special populations, older adults, for pregnant women, as well as, you know, for all groups, reducing the risk of excessive weight gain. And then we can think of populations where chronic disease is an issue. So thinking about managing people who have chronic disease. Again, the report shows we can reduce symptoms of anxiety and depression for folks who have chronic disease. So all in all, a whole lot of information, or new information around the health benefits of physical activity that are all contained in the advisory committee report. So, you know, again, what we do here at the Health and Human Services, we take that information and we translate it. So it's really user-friendly. It's great to have scientific information, but how do we distill it down so that health professionals can really use it? And so when we do that, we take that science base and we make guidelines out of it. I think what's new to this edition of the guidelines is, and we have incorporated that into the guidelines, is new evidence around sedentary behavior, new evidence around bout length. This version of the guidelines actually removes the bout length, so now any amount of activity counts. It doesn't have to be in 10-minute chunks. And then there's new guidance for youth, for preschool age children, 3 to 5. And there's a brand new chapter, the last chapter in the guidelines, chapter 8, around physical activity promotion. So I'm going to walk you through each of these kind of new pieces of the guidelines. So we'll start out with kids, with youth. So here are the evidence for the effect of physical activity for youth ages 3 to 5. It's mostly around its benefits for weight and its benefits for bone health. And when the committee, and when we kind of distilled this information down and looked at that evidence, we were confident that these guidelines would really help children ages 3 to 5. So we know that kids really need to be active throughout the day. There wasn't enough evidence to actually prescribe an actual amount or time to that. But it's very important for them to be active throughout the day. And really people who take care of kids really need to encourage active play in a variety of types. And so if you think of activities for this age group of kids, here are just some examples of ways to encourage children to be active. And so we try in the guidelines to obviously prescribe the guidelines, but also put in kind of, I don't know, user-friendly information to help the deliverers of these programs know what to do to put the programs into place, to actualize the guidelines. So there's information like this in the guidelines as well. And here's just some examples of activities for preschool age children. For a little bit older youth, these are school age youth, ages 6 to 17. If you're familiar with the previous guideline, this guideline didn't change much. There's a little bit wording difference here and a little order difference to the guideline, but it's essentially the same as it was in 2008. We moved the first piece of the guidelines about participating in enjoyable age-appropriate physical activities for school age youth up to the top, because we think this is paramount to getting kids to be active. You know, they need to have things that they really like to do and that are fun. And so that's why we moved that up. I think the hallmark guideline here is for aerobic activity, for moderate to vigorous physical activity every day, at least 1 hour. So an hour a day, every day is kind of the hallmark guideline for school age children. On 3 days a week, they should participate in vigorous intensity physical activity as well. And then there's also, I mean, I think sometimes these are sort of the forgotten guidelines, and they're for youth as well as for adults, but they're muscle strengthening activities. We want school age youth as part of their 1 hour a day on at least 3 days a week to participate in muscle strengthening activities and bone strengthening activities. And you might ask, well, what are those? Well, here are some examples that are also in the guidelines for muscle strengthening and for bone strengthening. You know, for bone strengthening, it's really about the impact of that force on the bones. So things like jumping rope, playing basketball, you know, sports that involve running, those kinds of things are really good to make bones strong in kids. So there's some examples of ways to get kids active and to improve their muscle strength and their bone strength. And so here's a picture of where we stand right now in the country in terms of how active are our youth in this country in terms of meeting these guidelines. These are data from high school youth in the country from 2011 to 17. You can see the blue line in the middle is around 25% of the population currently meets the aerobic guideline of an hour a day, every day. So that means that 3/4 of high school age youth don't meet that guideline. Muscle strengthening is a little better. It's almost a little over 50% meet the muscle strengthening guideline. So all in all, you know, my opinion, I think opinions of others, is we're not doing very well in terms of getting kids to meet the physical activity guidelines in this country. I think the other important thing to notice from this slide is that this is for high school age youth. So we don't have data, trend data for surveillance purposes to study, to benchmark really even kids who are younger than high school age. So that's an area that I think we need to work on as well. So that's how we're doing so far for kids who are school age. Let's take a look at adults let's take a little bit of a look at the evidence around the guidelines for adults. I mentioned earlier when I said, well, what's new in these guidelines? And actually, there's a whole lot of new evidence around sedentary behavior and its effects, primarily on mortality. Some information on other chronic disease states like cardiovascular disease and some cancers. But there's a lot of evidence around sedentary behavior defined as sitting time. And these are the 16 studies that were reviewed by the advisory committee. And what they show is this very nice kind of dose-response curve between sitting time and an increased risk of all-cause mortality. So the committee was really careful and smart. And what they said was there's a linear association here, but we really can't determine a cut point. There doesn't seem to be a point at which there's a lot more risk than others. So what they suggested is that, more sitting is not good for you. So there didn't seem to be the kind of this clear threshold in risk between sitting time and mortality, but definitely a great deal of evidence around the negative effects of sedentary behavior on mortality. They also took a really careful look at the combination between sedentary behavior and moderate to vigorous physical activity. So what if you have a really inactive job, you sit around like I do most of the day, but you're actually active, outside of work, for example. And this is a study, it's a meta-analysis of over 1 million people that tried to answer that question. What if I'm sedentary, but I am actually active? Can I reduce my mortality risk? And so if you kind of look at the left-hand side of this picture, what you see are the risks for people who are pretty active, 35.5 MET hours a week, but they also had this gradation of sedentary behavior here. And so what you see here is that if you're very active for about 60 to 75 minutes per day, you can actually reduce the risk, your mortality risk. If you're highly sedentary, you can actually reduce your risk of mortality if you're active. As opposed to, on the other extreme, on the other side of the graph here, this is pretty low levels of activity. You have increase in risk here. If you do a little bit of activity during the day, it doesn't really reduce your risk and come back down to this baseline level. So I think the message here is that sedentary behavior and moderate to vigorous physical activity are both important for your health. If you're really sedentary throughout the day, you can, if you're really active, 60 to 75 minutes per day, you can actually reduce your risk of mortality, but it takes a lot. 60 to 75 minutes per day is way on the extreme end of the distribution for moderate to vigorous physical activity. So what the committee did, and you'll see this not only in the committee report, but also in the guidelines, is they created this nice picture, this heat map that shows this gradation of the combination between sitting time and moderate to vigorous physical activity. Okay, so it's not just one or the other, it's really the combination of the two that can affect health. So we know sedentary behavior increases your risk of all these things that we talked about, but we know that moderate to vigorous activity can help offset the risk. And you'll see that kind of throughout the guidelines. So the first guideline that we have for adults, it's move more and sit less. So it's the combination of those two behaviors. And there you see it at the top. Some physical activity is better than none. So try and do some activity, you can get some benefit, but move more and sit less. And then the other guidelines are similar to the ones that we had in 2008. You can get substantial health benefits, and this is what the slide showed earlier, by doing at least 150 to 300 minutes a week of moderate intensity aerobic physical activity. We wanted to emphasize the range this time, 150 minutes to 300 minutes, because we felt like last time that people really just kind of honed in on that low level of 150. But 150 is really the minimal level that we want people to reach. We really want them to go over that. So we tried to emphasize the range in the second edition. And then for additional health benefits, try and do more than 300 minutes a week of moderate intensity aerobic activity. And then the adult guideline, again, also includes a muscle strengthening guideline and all major muscle groups on 2 or more days a week. So I think one of the things, how do these guidelines get developed? How do you determine these thresholds? I think this picture kind of nicely illustrates how we get to each of these 3 levels, right? How do we know that if you just move a little bit more, you can get great health benefit? And that's at this part of that curve. You can see that there's a great reduction in mortality, almost 20%, if you just do a little bit of leisure time activity in this graph. And again, this is from a meta-analysis of, I think, over 1 million people. Here the curve starts to, you get the kind of the greatest amount of benefit, a reduction in mortality, around 30% if you do 150 to 300 minutes of moderate intensity activity. And here's the piece of the curve that really matches to that 300 minutes of activity. And we see no increased risk at the end of this curve. So really the guidelines are definitely based on evidence from, in this case, many studies that have shown the benefits of activity to mortality. So what's the picture look like for adults in this country? This is a really long curve, almost 20 years now, of adults meeting the aerobic physical activity guideline in this country. We've seen a gradual improvement over time. It's about 0.9% over this time period. Seen a little bit of improvement. The current prevalence is around 53% of adults report meeting the aerobic physical activity guidelines. So some movement here. We're nudging our way up. It's not necessarily an unhappy story, but I think nearly half of the people in this country don't meet the aerobic guidelines. So I think we still have a way to go to get people in the country to be active. So that was adults. Now let's look to older adults, a really large and growing proportion of our population. So this is a guideline for older adults. It's very similar to the one for adults. So for older adults, if they can, they really need to follow the adult guidelines that you just saw. But it's really important that they include multi-component physical activity. And by that, we mean they need to include a combination of doing aerobic activity, meeting the 150-minute guideline for sure, muscle strengthening, and then balance is really important for older adults. So we want them to include all of these components of physical activity in the prescription that they achieve. And then if older adults have chronic conditions, like many of them do, they really need to understand how those conditions affect their ability to perform physical activity and hopefully meet the guidelines. So I think the key piece with the older adults here is including the balanced activities in what they do as part of their physical activity program. And here's just a picture of that around the multi-component. And that's the new part of the physical activity guideline for older adults. And here's some examples of activities for older adults. I think on the right-hand side for muscle strengthening, that's a good place to look at. I think we're probably pretty familiar with the aerobic activities on the left-hand side. But I think in this version of the guidelines, we point to yoga and forms of Tai Chi that we probably hadn't pointed to before. So just some examples here for older adults if you're interested in working with older adults. These are some data that we put out a few years ago, but we're trying to answer the question of, what's the prevalence of inactivity among older adults, number one, and that's kind of a grayish colored box. So here, about 20% of the population, ages 50 and older, are inactive during their leisure time. And then what is that trend, not trend, but what do those associations look like for folks who have a chronic disease? And so you can see that there's an increase in inactivity with age overall, and then also those adults who have a chronic disease are more inactive than those who don't. So here we have, kind of a multiplicative kind of a problem, right? Older adults are less active, and then those who have chronic disease are definitely less active. So I think this is one reason to, to try to intervene in this age group of people. So that's a little kind of an overview of guidelines for youth, for adults, for older adults. The last chapter of the guidelines is a new chapter. It wasn't there last time in 2008, but we thought it was really important for folks to kind of have a summary of the evidence about what works. And, because it's nice to know what the guidelines are, but I think it's really great for health professionals and research folks to know what actually they can do. So we wrote a chapter in the guidelines that really summarizes into how we promote activity, how we get people to be active in two ways. You can look at it from an individual or small group perspective, those types of strategies that work, or from a community perspective. And in this green box, these are the strategies that work for communities. And I'm going to walk you through just a couple of examples here. So for individuals or small groups, we know that walking programs really work. These are the kinds of programs like you see here, Girl Trek, aimed at African American women, kind of uses a civil rights approach to try to instill walking as a social movement. Walk with Ease is a program developed by the Arthritis Foundation to encourage walking for people with arthritis. So these are some examples of really social support types of programs that are available for folks to join. There's also the idea of prescribing physical activity to people, and that's I think the strategy of receiving guidance from professionals. This is just an example of a prescription pad from Exercises Medicine, where healthcare professionals can prescribe physical activity to their patients. So these are some strategies that work with individuals or small groups. There's also a lot of evidence, actually, that technology can help improve physical activity. This is, I think, one of the nice parts of the advisory committee report. So we know that these trackers, accelerometers, pedometers, even apps actually help encourage physical activity. So when you give participants this kind of information, they tend to be more active. But you have to pair that with goals for them. It's not enough to give them the device. You have to pair it with a goal, kind of a behavioral approach to becoming more active. So when these things are paired, they tend to work. There's also, when you think of technology, you can deliver it, person, face to face, or you can deliver information or coaching virtually. So there's evidence that these types of remote delivery systems work, whether it's via telephone or virtual coach or even text messaging. Those types of strategies will improve physical activity. So that's kind of on an individual perspective. What do we know from our evidence with communities? We know from the Guide to Community Preventive Services that point of decision prompts work. These are mostly stair use studies, trying to encourage taking the stairs rather than the elevator. Lots of studies that have looked at that. We took that idea, that strategy, a couple years ago, and we employed it in the Atlanta airport. We put up signage really just to encourage travelers to choose an active form just to encourage them to walk to their gate instead of taking the train like you see here. And at the end of that intervention, we saw 11 to 17% increase in number of people walking over that time period. And then just over that time period, which was about a couple years, we estimated almost 400,000 more people walked during that study period. So I think, these kinds of strategies that are relatively inexpensive compared to others, as long as they're employed in large populations, might have some application. And then we also translated that information to an airport walking guide so that airports could use this strategy and employ this strategy in other airports across the country. I think you guys probably know this strategy by heart. Again, it's from the community guide. It's really about how do you make sure that that places and communities are actually connected. So we like to think about it as connecting routes to destinations. So it's not enough just to have a sidewalk. We need to have a sidewalk that connects us from our home to work, from home to school, etc. So we like to think of it as connecting activity-friendly routes to everyday destinations. And this is a community guide recommendation of almost 100 studies looking at these two types of systems approaches to improve physical activity in communities. So if you think about, just kind of easy ways to employ this strategy, here's some examples from Austin and from Oakland of some people will call these approaches quick builds or lighter, quicker, cheaper. But these can be temporary installations to improve the built environment for physical activity or for walking and biking. Here you see an example from Austin where they just painted in some crosswalks and bump outs, and one from Oakland, California, where they put up a temporary protected bike lane. And this is the mayor of Oakland riding his bike on that bike lane. So here, I think that the beauty of this is that we hope that these kinds of lighter, quicker, cheaper strategies not only create opportunities for physical activity, but that they're also policy accelerants. So that if key decision makers or key influencers in communities see that these things work, they may be more likely to pass policies to promote physical activity, whether it's complete streets policies, passing master plans or zoning policies, that these are accelerants to that policy change that we really want to see. And so if you look at the complete streets policies that have been adopted in the US over time, we started out pretty low in 2006 with 10 state level policies and 36 regional policies adopted. And now, at least in 2016, over 32 states, and I think it's over 1,200 regional policies have been adopted. So I think we're making really good progress in terms of complete streets policy adoption. It's really as you all know, probably much better than I do, it's really the implementation that's the question now. And then the chapter also talks about how we can work together to take action to really improve physical activity levels in this country. And it's really going to take this concerted effort between our sectors, getting our sectors to come together, whether it's healthcare and community sector or even sports, kind of coming together to promote physical activity. So one sector cannot do it alone. It really takes a concerted effort of all these sectors coming together. And then the guidelines, the Department of Health and Human Services has done a really great job developing the Move Your Way campaign to promote the guidelines. And they have many different forms of materials that you can access. They're all free. There's an interactive tool that's kind of a tracker where you can track your physical activity. Lots of posters and fact sheets. I believe there's one for adults and for kids, as well as some videos that you can download. So if you're interested in using these in your presentations or in any other work that you might want to do, they're all free, all accessible on the website. And then the last thing, I think Keisha mentioned this at the beginning in her introduction, we really see our role as trying to improve physical activity in the country. We work with over 60 states, communities. These are recipients of our funding, and we really implore them to implement the community guide recommendation to provide activity-friendly routes to everyday destinations. But we have a larger initiative called Active People, Healthy Nation, whose aspirational goal is to improve the physical activity levels in 27 million Americans by 2027. And we really want to do this together, working across all the sectors by using the community guide strategies as well as other strategies that I mentioned before. So this is our kind of our big initiative now, and we're rolling that out as we speak. And with that, I'll say thank you very much.
Great, thank you so much, Janet. This was terrific. We already have questions in the chat box. I have questions. I know other people do as well. So really appreciate you presenting an overview of these guidelines. The first question in our chat box is, was the majority of the evidence for the PA aerobic guidelines based on self-report or objectively measured literature? Can you speak to that, please?
Sure, great question. Yeah, there are many more studies now that have used accelerometry than previously, but I will say the majority of the studies to date are using self-report methodologies and comprise the majority of the data I think that you see in the guidelines. Many of the accelerometry studies they weren't published at the time that the committee reviewed the evidence, so we missed that a little bit. But yeah, it's a great question. The devices are now being used in many cohorts across the country and actually across the world. So I think in the next 3-4 years we'll have an incredible amount of evidence using accelerometers or even pedometers. Yeah, it's a great question.
Great, thank you. Let me pause and make time for questions from folks on the phone.
Keisha, I'll actually read one that Nisha typed in. She's in a noisy environment. So she said she's interested to hear if Janet thinks summertime can help address physical activity participation in children and adolescents, and what venues or interventions offer the greatest likelihood for success with low-income kids across urban, suburban, and rural environments.
Great.
Yeah, good question.
Yeah.
not sure I have the great answer for that one. Yeah, you're right. I mean, during summer, physical activity levels in kids definitely fall off. I think, again, there's you can think of there are many resources in communities, whether it's through Boys and Girls Clubs, those kinds of things, through programming, are great ways to try to instill, physical activity into the days of kids during the summer. I think, when we think about using community-based approaches to promote physical activity by making it really easy and safe for everybody to walk, that's when we also hit kids too. So I think, when we think about, kind of deploying these population-based strategies by making environments activity-friendly, we hit on kids too, particularly during the summer. Kids should be able to ride their bikes, from place to place. They should be able to walk from place to place, in addition to having places to go to be physically active. So if you think about policy approaches like shared use, with, for example, schools or YMCA's, let's create those, those kind of shared use policies where schools are open for kids to use during the summer, or even, other facilities are open for them. So I think there's a variety of approaches that you can take for kids, during the summer or during the school year as well. We did I think it was published in 2013. We reviewed all the evidence on youth physical activity programs and policies, and that's in it's called the Physical Activity Guidelines mid-course report. that's available as well on that website that's up on screen. So if you want to take a look at that, I think it gives some information as well. It's a really good question.
Great, thanks, Janet. We have a follow-up to the earlier question about using self-report or objective measures, and the question is, would it be better to use self-report to assess adherence with surveillance? And if you need more clarification, we can ask Stephanie, who asked that question, to elaborate a bit.
Yeah, I think, surveillance is an interesting question. It's a great question, Stephanie. For surveillance, we're really interested in having consistent measures over time. And we have to have used the same, kind of collect information on the same population of people with the exact same methodology over time to look at those trends in a scientific way. So, in some populations, it's feasible to use devices like accelerometers. Like, for example, I think everyone knows about the Haines surveys that have been done over time, at least the one that's been out now. I think, there are some challenges to using devices in large surveys. For example, we have one survey that's almost 500,000 people, the Behavior Risk Factor Surveillance System. So while we're getting probably more accurate data on the actual movement of individuals, we also have to look at the feasibility of using a device to assess physical activity in that kind of a setting too. So I think it really depends, what the goal is of using devices versus self-report, where we can call people, ask them some questions, and get at the information that we want, probably in a little more cost-effective way. But yeah, granted, it's probably not as accurate as using a device to measure the activity. But we, and actually here at CDC, we are highly interested in examining issues around using devices for surveillance. We have several groups here that are looking at that, and we've looked at that too. We get the question a lot around, why don't you kind of tap into the consumer grade information that's out there, like with Fitbit or other types of devices, and we're looking into that as well.
Great, thank you. Janet, there's another question about, are there any specific guidelines for college students, or did the committee talk about that at all? Yeah. There are no, in this version of the guidelines, there are no specific guidelines for college age students. They would fall in the adult guideline as long as they're 18 years of age or older. So we would want them to do minimally 150 minutes of at least moderate intensity activity a week. We did have, I would say, the advisory committee had much discussion on the time period post high school to college, because how that guideline changes. So when you're a kid, right, you have to do an hour a day every day of aerobic activity. But then when you hit that magic age of 18, the guideline changes to 150 minutes. So it's sort of interesting, how the guideline changes over time and how activity levels change over time. I think when the committee kind of tried to take a look at that, there weren't that much data following youth, kind of the high school age youth into early adulthood. So I think, from a research perspective, that's an area that really needs to be looked at. Yeah, great, thank you. Yeah, it is certainly a question, like what happens in that transition period, right? Like, and how do people change from adapting or adhering to one set of guidelines, and then all of a sudden you're in the next group, and how does that, in fact, play into your life? Yeah. Interesting area. It is. Mm-hmm. We had another question, Janet, online, and then I'll turn to the phone. So there was a question that said, can you provide any guidance on the amount of time to recommend people in terms of interrupting sitting? So, for example, should we tell people to stand for 2 to 5, minutes every 30 minutes or hour? Or do you have any guidance about that? Yeah, I wish we did.
the committee, as they examined all of these studies on sedentary time and health, they felt like there wasn't really a threshold there that they could recommend with a great deal of confidence. They did not feel that there was the evidence to kind of hit on a number. I think your question's a little bit different than that, though, is, how often should you take a break, and what kind of break should you take when you take it, and, is standing better than sitting? I think that the evidence there, it's not actually included in the committee report, I don't believe, but there are many groups around the country, mostly in Australia, who are looking at that, and I think, just from what I've read and heard, it's really about, it is about taking a break, it is about standing up, but it is about moving around. It's not necessarily just standing. It's about moving around that actually can have some health outcomes. But that's not in the. I don't believe it's in the committee report, and it's definitely not in the guidelines.
Great, thank you. Let me see if there are other questions from people on the phone.
Keisha and Janet, it's Jamie. I don't have a question, but I just want to thank Janet and the CDC team. Every time I'm in the Atlanta airport, I think of you guys because I actually follow the signs and walk my way through from C all the way to T or whatever it is. So, and I forced my husband to do it too. So thank you for the public service.
Yay, we have one. Thank you, Jamie.
One. I always look up at the video monitors to see if maybe you catch me and wave.
Oh, definitely. Definitely. Good to see you.
Thanks, Jamie.
Thanks, Jamie.
So, Janet, there's another question on the chat box that says the evidence review says that there is quote unquote limited evidence for worksite interventions to improve medium and long-term PA. What do you think is the best strategy to get employees moving more?
Yeah, good question. I mean, I think, work site's not, I would say, not my area. I mean, I think there are many strategies that have been put forward around, you can have their program. I mean, these are not, I think the committee really came down on the limited evidence around these, but yeah, I think we all know there are lots of strategies, and you know this, Keisha, that there are, programs that can be, instituted in work sites. There are ways to improve facilities, whether it's bike racks or showers. And then, one of the areas that we're really interested in is how do you get communities to make sure that there are ways for community members to actively travel to the work site, so making sure that there's, sidewalks and bike lanes and those kinds of things that allow that opportunity. And then also, are there places, around the work site that can help facilitate activity, walking trails and things like that. So I think there's a lot of ways. I think, there's, in terms of the concept of active travel to the work site, I think that's a real nice avenue to try to do some good studies there.
Great. Let's see if anybody has a last question. If not, I'll take it. But let me pause and see if anybody else has a question before I jump in with mine. Okay. All right. Well, let me ask my question then, Janet, before we let you go. As you know, I do a lot of work around safety and injury prevention too, and just my colleagues and who work in that world, who don't interact much with the physical activity side, are always wondering, what's the thoughts around mentioning or including more information around safety and injury prevention in things like guidelines for physical activity. And so just wondering if you can share with us what the committee thought about that. I know you mentioned balance for older adults, which clearly connects with safety, but clearly people are also thinking about pedestrian safety and bicycle safety. Yeah,
thank you. There's actually a chapter in the guidelines. It's pretty, I think it's really well done. It's, the message of start low, go slow, I think comes up for a lot in that chapter. I think there's a lot. One of the new pieces of evidence was around falls in older adults, how physical activity not only can help prevent the fall, but actually helps with injury from the fall. So that was a new piece of evidence that emerged within the review. But yeah, I mean, I think, you know, and when we wrote when the Surgeon General wrote the call to action to promote walking and walkable communities, we had quite a bit in there around safe walking, you know, and this concept of, you know, distracted walking, people looking at their screens and that kind of thing. So yeah, I mean, I think, you know, marrying up the physical activity world with the injury world is really important. It's super important. I know that the bicycling community is highly interested in that. When you think about programs through the Department of Transportation like Vision Zero, you know, getting to zero fatalities on the road. I think, you know, that coming together of the health world and the transportation world around safety is probably an opportunity to pursue.
Yep. Great, agree. And what a great way to end our time today. And Janet, your presentation, just lots of positive comments on the chat box, and just want to thank you. It was terrific. Really appreciate your comments and your time today. It was great to hear you walk through the guidelines. Before we wrap up, I just want to thank everybody again for making time today. Our next call is on March 28th at 1 p.m. and we already have the PARC, the Physical Activity Research Center team, signed up to present their work as they're coming to the end of their research projects. And I wanted to briefly mention that Hillary Seligman, who runs NoPrint, and I are trying to set up a joint webinar to help think about NCORE, to have a presentation on NCORE tools, measures, and registry, and we're looking to do that in either June, July, or August. So I would love to hear from people in terms of your preference for one of those dates. I know holidays are in there, but please let us know if there's a strong preference for one of those dates. If not, we're just going to probably go with the June date and hope that individuals are able to be on to hear and learn more about NCORE's tools, measures, and registries, and how we can connect more with NCORE. All right, so thank you again, everybody. Really appreciate it. Hope you have a great day and look forward to seeing you all, or most of you, in a few weeks in South Carolina for ALC. And please look out for our emails about that, our gatherings at that meeting. Thanks again to Janet, and we'll be in touch soon. Take care, everyone.
Thanks, Keisha.
Nice job.
Thanks, Keisha. Thanks, everybody.